Well, first I'd like to thank the NCCN for the opportunity to speak to you all today. So to start with, for radiation, so women who undergo breast conservation therapy typically have radiation following their lumpectomy, and the typical is whole breast radiation, goes on Monday through Friday for about 6 weeks. And it's selectively omitted in older women with, good prognosis disease. So women who are ER positive on estrogen, on anti-estrogen therapy. And there are a couple different options for women who want to do a little less radiation therapy. So I'm going to talk a little bit about hypofractionation and then a little bit about partial breast radiation in a little bit more detail. So we have a question for the audience response system. So a 50-year-old woman undergoes a partial mastectomy for a T1CN0 invasive ductal carcinoma. She's triple negative, and she has negative but close margins within 2 millimeters. So what type of radiation would you recommend? Standard whole breast radiation, standard whole breast with nodal radiation, standard whole breast with a boost of the tumor bed, or accelerated partial breast radiation? Okay. So we can go back to the slides? All right. So a little bit of variability, which I think your responses highlight the fact that there's a lot of different ways to approach radiation in patients. And I'll talk a little bit about kind of boost and hypofractionation again, in which patients are eligible. But hypofractionation in general is a shorter course, fewer fractions of radiation with a higher radiation dose per fraction. And women who are, whether or not a woman is a candidate for this really depends on her tumor location, kind of the physics of her treatment planning, the characteristics of her cancer. And, the Astro Choosing Wisely campaign has really tried to kind of promote this as a means of radiation because ultimately it's better utilization of resources for women who are capable of having this kind of radiation or who are eligible for this kind of radiation. With the NCCN guidelines, the recommendation is actually to promote hypofractionated radiation for women who are eligible for that radiation. So specifically, again, they comment that the short course is preferred, and typically that's 15 to 16 fractions as opposed to the typical 25, roughly, fractions with standard whole breast radiation. So the Astro consensus on hypofractionation was published a couple years ago, and this is actually a really helpful consensus statement. So which women should we be offering hypofractionation to? And they did a great literature review, and if anybody hasn't read this consensus statement, it's definitely worth reading. It's very helpful. But specifically, they looked at the data available comparing hypofractionated radiation to whole breast radiation. And those were the bulk of the studies included in this. And ultimately, what the consensus panel decided is that hypofractionation is a great option for women who are 50 years and older at the time of their diagnosis. They're pathologically T1 or T2N0, not DCIS. They have not required or needed systemic chemotherapy. And then there are certain dose recommendations in terms of the actual treatment planning. Now, I think the important thing to know about this consensus statement is that the experts on this panel did not say that patients who don't meet this criteria are not eligible for hypofractionation, and in fact, other patients may be good candidates for this, but the data wasn't there to really form a consensus unanimous opinion. So that's hypofractionation. So I'm going to talk about even shorter radiation with accelerated partial breast. And just show of hands, how many people are regularly doing accelerated partial breast at their institutions? So okay, good. So accelerated partial breast radiation typically is a 5-day course of radiation, and there's multiple ways to deliver the radiation. And one of the first kind of developments was balloon catheter, specifically the brand Mammocyte, which has been used now for over 10 years. I'm going to talk a little bit about that. Multi-catheter brachytherapy, there's other single catheter devices. I'm not really going to talk about external beam radiation or intraoperative partial breast radiation. I'm really going to focus on the catheter-based therapies. So again, back to the NCCN guidelines, accelerated partial breast radiation is included in the NCCN guidelines with the caveat that there is limited follow-up on these patients, and there might be some concerns in the published studies about cosmesis. So again, those are really the caveats in the NCCN guidelines. The NCCN guidelines also reference the ASTRO consensus statement regarding who is a candidate or a good candidate for accelerated partial breast radiation, and I will talk about that in just a minute. So the ASTRO consensus statement specifically looked at studies available to determine which women are good candidates for accelerated partial breast radiation and which women are not, basically. And they actually divided women into 3 different groups: suitable, cautionary, and unsuitable. So ultimately, women who are suitable or great candidates for accelerated partial breast radiation are women who are at least age 60, they don't have BRCA mutations, they have small T1 tumors, and it's invasive disease. Their margins are at least 2 millimeters in terms of negative margins. Typically no lymphovascular invasion in these tumors, ER positive unicentric tumors, really no pure DCIS, and again lymph node negative. Now, women in the cautionary group, of course, these guidelines relax a little bit. So these are women a little bit younger, so women 50 to 59, tumors up to 3 centimeters in size, which may include some lymphovascular invasion and some DCIS. And if there is pure DCIS, less than 3 centimeters of pure DCIS to really be a good candidate, or at least a cautionary candidate. Margins had to be negative, but close margins are included in this cautionary group, and again, that would be margins less than 2 millimeters. Of course, this consensus statement, these guidelines were created before the most recent ASTRO SSO guideline on recommendations for negative margins. So patients who are considered really unsuitable for accelerated partial breast radiation are women under 50, basically premenopausal women. Women who have BRCA mutations would not be considered candidates for this. Tumors at least 3 centimeters in size. Margins that are positive really should not undergo partial breast radiation. Extensive lymphovascular space invasion or an extensive intraductal component of DCIS, and women with lymph node disease. And women treated with neoadjuvant chemotherapy really are not considered candidates for accelerated partial breast radiation by this set of guidelines either. So now that we've kind of talked about who can have or who should or should not have accelerated partial breast radiation, I want to talk a little bit about the different technologies. So again, one of the first devices used for this is balloon. It's a balloon catheter used to deliver the radiation, and Mammocyte was kind of the first kind of big company that had technology on the market and was probably the most widely used. And the American Society of Breast Surgeons and Mammocyte together created a registry and started registering patients back in 2002 to monitor outcomes. So for those of you who haven't seen what this looks like, there is, let me see if I can use this pointer here. So this is the actual balloon catheter. So basically it's put in either in the operating room, actually in a procedure room after you've gotten your final surgical pathology and you know your margins are negative. But basically the catheter is inserted into the skin a little bit away from the lumpectomy cavity, and that balloon then sits within that cavity. Women go home with that balloon, and that balloon is in for the 5 days that they're getting their treatment. And it looks a little barbaric when a woman is going home with this, but actually women tolerate this really pretty well. And the balloon itself is filled with contrast, so that on the treatment planning CTs you can see the balloon nicely. And there are a few caveats to this type of radiation. So specifically, you have to have at least 7 millimeters ideally of a skin bridge. So that area of skin between the catheter and the skin should be at least 7 millimeters to reduce toxicity to the skin. Distance to the chest wall also matters, and then the cavity itself has to conform nicely to the walls of the balloon. So if the cavity is larger than the balloon and there's basically airspace between the balloon and the edge of the cavity, that's not good for treatment. But ultimately that balloon is then hooked up to the machine which provides the radiation, and this is a patient who is post-treatment. So overall, good cosmetic result in this patient, and I'll talk a little bit about the cosmetic results of this treatment. But again, really it's a centimeter or so around the lumpectomy cavity that gets the radiation. So most of the breast is spared the radiation dose and therefore the radiation side effects. So actually last year, actually in 2013, the final results of the American Society of Breast Surgeons and the Mammocyte Registry, their final results were published. And overall, their median follow-up was 63 months, and their results were really pretty good. Now, most of the women in this registry had invasive cancer, not DCIS. So overall, a small percentage of women were pure DCIS. But as you can see, the overall recurrence rates for 5 years were overall low and certainly acceptable and within the range of standard whole breast radiation. So for the invasive cancers, ipsilateral breast tumor recurrence rate of 3.7%, a little bit higher with pure DCIS, not too much of a surprise there. And specifically that TRMM failure rate, those are true, probably under treatment recurrences. So those are recurrences that either were really right at the margin of the lumpectomy cavity. So something kind of missed right at the margin in terms of the treatment, whether that was surgery or radiation. So again, that was about half of the recurrences that they saw in their study. Overall, low rates of distant failure, as you would expect. These are otherwise early stage breast cancer patients. So the factors that they looked at to determine, which women were at higher risk of having an in-breast tumor recurrence or any type of disease failure. So as far as what was actually significant, larger tumor size, no big surprise, higher rate of recurrence, specifically for invasive cancers, but for DCIS as well. ER negative tumors, as with all sorts of both surgery and radiation, had a higher risk of recurrence. Margin status, interestingly, was not a significant predictor, although it was close. So closer and positive margins had trended towards a higher risk of in-breast recurrence. And then they actually broke women up based on those ASTRO consensus guidelines, so which women were suitable versus cautionary or unsuitable. And that, again, was kind of borderline significant. So women who were treated under the cautionary or unsuitable category, women who would have fallen into that category, did have a slightly higher risk of having disease recurrence in the treated breast. Now, I didn't show the data here, but in terms of their cosmetic results, the authors actually presented rates of fat necrosis, seroma infection, pretty comparable to what has otherwise been published in whole breast radiation. I'll tell you, I look at those numbers and they still look high to me. And as someone who's seen women who've been treated with Mammocyte, I don't know how many of you otherwise have taken care of women who've had the balloon brachytherapy. It's a great technology, but I do think that the fat necrosis at the lumpectomy side and the persistent seromas are problematic, more so than with whole breast radiation, although, again, the data published by this registry didn't really show that. So, given kind of these caveats of partial breast radiation, why are we still so excited about it? We've got these concerns potentially about a poor cosmetic outcome, more fat necrosis. We really don't have great long-term data on recurrence. And, follow-up, beyond this 6.3 years in this registry may show that recurrence rates are higher the further out we go. We don't really have that information yet. And again, a lot of patients really don't like the sensation of a really big lump at their lumpectomy site. It bothers them and it makes them nervous, understandably. They worry that their cancer is back. But there are huge benefits to this kind of treatment. So I don't know how many of you take care of patients who are coming in from far away as a tertiary referral center, but for women who are traveling a large distance, this is a great option for them. They can come, they can stay in town for a week instead of having to drive somewhere every day for 6 to 7 weeks. So in terms of patient access, I think this really is great. Patients, even if they live in town, they like it. It's convenient. They can kind of take a week off of work and putz around the house and get their radiation treatment without having to deal with, again, a month and a half of getting treatment. And in terms of the cosmetic outcomes, I think there are women who have really bad cosmetic results with whole breast radiation. And there are, granted, women who have bad results with this brachytherapy as well. But I do think that there are women in whom the cosmetic result may be much better with partial breast radiation because, of course, most of the breast is getting spared radiation. Depends a lot on the patient, the treatment planning, that sort of thing. But I do think that there are excellent cosmetic results with this treatment as well. And so all of these things make this a worthwhile technology. So multi-catheter brachytherapy, I'm not going to talk about a lot. I don't know how many people here are doing multi-catheter brachytherapy. We actually used to do quite a bit of this at WashU. And for those of you who haven't seen it, it looks barbaric. You women literally have 24 catheters coming out of their breast all around the cavity. And very much like Mammocyte, they're treated twice a day for 5 days. And again, it looks horrible. But I'll tell you, women actually tolerate this very well, and the cosmetic results are great. The ability of the radiation oncologist to do their treatment planning, it's, I think radiation oncologists like it. And in fact, at WashU, our radiation oncologist actually is the one who places all these catheters. So even as a surgeon, I don't do this, he does this. But again, I just kind of want to show, because if people haven't seen that, I think it's a kind of hard to picture in your mind. But we've really stopped doing this recently because of what's called the Savvy device. And this isn't, I don't want to promote one brand or another. This is just one of the non-balloon devices that I'm most familiar with, because this is what we use. And so I do want to talk a little bit about this and why I think it's replaced those multiple interstitial catheters. So Savvy stands for Strut Adjusted Volume Implant. Basically, it's very much like the Mammocyte balloon in that you have kind of this tail that comes out of the breast, and then you have a portion of the device that is sitting inside the lumpectomy cavity, very much again like the Mammocyte. The difference is that it's not a solid balloon. It's literally these individual struts that come in, and there's a couple benefits to that. So one is, I think there is some element of the surrounding tissue being able to kind of sneak in around the struts a little. So I think the inside of the cavity isn't kind of sprung out and radiated into this really big round ball. So I think the final cavity ultimately can be a bit smaller and less prone to seroma. But because of these different struts, radiation treatment can be planned differently in each of these struts. So say you have a tumor that's very close to the skin, that's not an issue with this. You simply modify your radiation planning so that these struts don't deliver radiation to the skin. So it allows for a little bit more flexibility in terms of who we can offer accelerated partial breast to, given this. And ultimately, again, this is anecdotally, but the cosmetic results seem to be good because women seem to have less of that fat necrosis, less of that really hard kind of snowball sitting in the breast that we've seen with some of the other devices. There's not a whole lot of data out there about this device in terms of long-term follow-up, certainly nothing as long-term as we've seen with Mammocyte. I really wasn't able to find much at all in the way of cosmetic follow-up with this device, except what I can tell you anecdotally. This was a series that's not even published yet. It was presented at ASTRO this past year, and this was about 600 patients with a 39-month follow-up, specifically treated with this strut-based device. Most of these women had invasive cancer, 69%. They were overall older patients, median age of 63, and they had small tumors. Although you can see that there were a few tumors as large as 6 centimeters, which it's hard to wrap my brain around having a cavity small, that took out a 6 centimeter tumor and being able to use this catheter in, but and mostly ER positive. But again, overall, their recurrence rates, both for invasive and DCIS, were really pretty low. Again, it's only 3-year follow-up, but the recurrence rate 2.4% for invasive disease and about 4% for DCIS. So as we saw with the American Society of Breast Surgeons registry with Mammocyte, higher rate of local recurrence for patients who have DCIS versus invasive disease.